Good evening, good morning, and good afternoon. We are back here again with our next presentation at Global Summit. And Dr. Kianor Shah has given me this responsibility today to introduce my speaker, host the program today all alone. We had a wonderful presentation a few minutes back by Dr. Irfan Qureshi from Karachi, Pakistan. And now here we are with our new speaker for today, the second speaker, Dr. Sonia Regina. She is from Brazil. Basically, she belongs to Brazil, and she is going to give us an insight into the dental lasers. And let me tell you about something about Dr. Sonia. She is a DDS. She has done her MSc, and she is FIA DFE. So she's here and she's going to talk a lot about photobiomodulation and what lasers can do with a holistic approach into the healing. Because healing with a natural healing where you are activating your cells, and a laser therapist is going to activate the cells and let the body heal on its own to have the and that is something which is holistic. Dr. Sonia is an internationally acclaimed expert in minimally invasive facial and dental aesthetic procedures. She has 3 decades of international experience. Wow, amazing. 30 years. Using laser biotechnology in UK, Brazil, and now in US. She successfully runs her International Academy of Oral Facial Harmony from Dallas, an American European laser teaching center specialized in training healthcare professionals in various parts of the world on the use of lasers in dentistry and in aesthetics. She is also actively involved in clinical practice in a partnership with a craniofacial sleep and laser wellness center. Wow. And in Dallas, with a holistic approach to orofacial harmony. I think it is going to be a very interesting presentation. All of you, you are going to hear about a lot about all kind of lasers.
Mhm.
She's front runner of photobiomodulation lasers for dentistry in UK and Brazil in 1990. She has a master's degree from the Eastman Dental Institute, London, UK, and continuously do research and publications in the area of lasers in cooperation with 3 major international affiliated universities: University of Sao Paulo, Brazil; University of Nevada, US; and De Montfort University, UK, from which she's currently working towards her PhD in lasers in biomedicine. Dr. Sonia is on the editorial board of some major peer reviewed laser journals, and in 2020, she was elected vice president of the Pharmacology, Therapeutics, Toxicology Group of International Academy of Dental Research, IADR, and granted the Top 100 World Doctors Award in Dentistry. So today, here, I'm going to present in front of you Dr. Sonia Regina, originally from Brazil, now in US, and working since last 30 years on lasers, and she's going to give us a whole lot of insight into different kind of lasers like diode and hard and soft tissue lasers, and low intensity lasers, the low laser therapy into the myofunctional areas, and facial aesthetics, and lot many things. So here I present Dr. Sonia in front of you. Thank you so much and welcome to Global Implant Summit webinar series.
Good afternoon and good morning, depends what part of the world you are. Thank you all for being here today to listen to this presentation. I would like to extend my gratitude to Dr. Kianor and Dr. Gupta and the whole team who has been working hard for these 2 months to make this global summit possible. You can type there where you are, in which country you are, to see all the people who have been taking part on this summit. And I realized that I think yesterday we reached 1,500,000. Dr. Kianor, that is incredible. I don't need to say much about me because I already been introduced. I just want to declare that I have absolutely no financial interest in any information I'm going to be presenting here. And I'm going to talk about various lasers, not just photobiomodulation. Basically, I'm going to give a wrap up of all the lasers out there and what you can do with them in dentistry and facial within the limited scope of time we have. Um, the outcome I wanted to take from this is to understand how the laser parameters is going to directly influence your outcome and what you should be looking for on a laser. I'm not going to be talking about clinical indications, clinical training, clinical case presentation, or safety training. We don't have time for that, and it's widely available out there. And we run courses also if anybody's interested. Why should you consider buying a laser, or how to choose the right laser? What can a laser do for you? A laser can do most procedures for you because now modern technology allows that, and it can do it with great precision and speed, either in dentistry or aesthetics. Or shall I say both? The ideal laser for you to choose would be the one that within the same device you can do a variety of procedures with speed, precision, minimal thermal injury, which offer you a smooth cutting, coagulation, but also is cost effective and cost offers you a good cost benefit. So I know people like to talk about cost benefits, so I put in here a ROI, a return on investment table for anybody who was considering buying a laser and has no idea where to start. Basically, these costs are based in US, and we have here diode lasers that range from $3,000 to $7,000. And we have all tissue lasers from 50 to 150,000. If you bought or leased that laser over a period of 5 years, say a cheaper diode will cost you $50 a month. Over a period of 40 working hours a week, you'd be paying 30 cents per hour for the use of that laser. And with the all tissue lasers, the one that offers you also some handpiece for snoring and for facial aesthetic procedures, you talk about paying per month $2,500, which is $15 an hour. But having said that, this laser would offer you extra procedure that you could do in your dental practice that would probably bring this money back very quickly. And if you divide, say, let's if you do two patients per hour, that 30 cents is going to be 15 for a diode, 15 cents, and your $15, say, $7.50, and that's probably going to be the cost of your PPE now with the current COVID crisis. So if you're thinking or considering to buy a laser, you must first base your decision on science. And there are lots of papers out there, evidence-based. You just need to do a search and you have everything. Now, before you get frightened that I'll be here talking about physics, I will not be giving a physics lecture. I'll be basically pointing out the factors on your laser machine and on your laser settings that's important when you are doing specific procedures. So all these contents are going to be intertwined with the clinical relevance. So I'll talk about laser tissue interaction, the modes of delivering the laser energy, the properties of the biological tissue, comparative studies, mechanism of action, and laser ablation against the how is that influenced by the delivery mode of your laser, but all this in the context of the clinic. In laser tissue interaction, basically, I just want to point out that those properties of light that you learned back in school, the reflection, absorption, transmission, and scattering, the degree of which each of those properties are going to behave, the amount of reflection, the amount of absorption, etc., is going to be determined by your host, your tissue host. So basically, the composition of your tissue is what's going to determine the various degrees of the light property behavior. And now already on section 2, the modes of delivering the laser energy. So your device is also going to be important on this interaction with your tissue, because there are a number of factors in the device that's going to directly influence that. So for instance, the wavelength or the light frequency is going to directly influence the tissue absorption and the tissue penetration. Sometimes you don't want the laser energy to penetrate because you want to do just a superficial ablation. But say if you're doing photobiomodulation or you're doing skin rejuvenation, which involves, for instance, non-ablative technique, and you want to do some denatured protein below and the level of dermis or subcutaneous tissue, you want that wavelength to be able to penetrate. And the other thing, for instance, laser hair removal. The light has to go deep down to your hair follicles, otherwise it's not going to do anything. So wavelength is very, very important. The spot size of your beam is going to directly also influence the penetration. And as I said, sometimes you want the laser energy penetrate, sometimes not. Normally when you're doing ablative technique, but for everything else, you want your lights to penetrate. It's been shown in the research that spot size of a laser beam above 4 millimeters is ideal for producing less scattering. Remember, it's the light property. So it's less scattering, therefore it penetrates deeper. So if you want to increase penetration, you want to work within the 3 millimeters, 4 millimeters or above spot size on your laser beam device. Again, that's not related to ablation or cutting, okay? Other factor is the beam profile shape. You have beam shape, traditionally they are Gaussian, which is the one that you can see here has a curve, or you can have flat top hat or flat top, we also call it. The problem with the Gaussian is that you have extra heating at the two ends. Look at your picture on the left. You have extra heating energy that is wasted in the two ends. And the top hat is much more, the spot diameter of the beam is more evenly distributed. So if you look at in your right picture, you can see them, the shape against a piece of material that was ablated, was ablation, cutting. And you can see the nice quality of the cutting with the top hat, very evenly distributed, the energy, and the quality of the Gaussian which is much less evenly distributed. There's a lot of energy wasted there too. And that can cause you, contribute to further thermal damage that you don't need. The power of your device also, pardon, is going to influence your laser. So for instance, in ablation, when you're cutting, okay, or evaporating or pulverizing your tissue, if you increase the power, you increase the velocity, the rate of ablation. If you increase the pulse repetition rate, say within the same power, you also can increase your ablation rate. Look at the blue line on the right, ablation rate. So you can cut faster by either increasing the power in watts or by increasing the pulse repetition rate. How many pulses per second am I giving? That's when they say, increase the frequency. The frequency they talk is not the frequency of light, it's the frequency of the pulse. How often do I pulse? And that's very important for you to remember, start to remember these names. Now the power, I said about increasing power or increasing the pulse repetition rate. I'm not going to be here again giving you physics lectures, but I want you to understand that the amount of energy that is going to be delivered can be the same despite you modifying your power or your pulse repetition rate. And I'm going to show you how this works. The energy, if you look at a triangle, if I don't know if you learn that like that at school, but if you get your energy equals to the power times the time, so you can get the area of the power and your time in seconds to represent the amount of energy. Okay? Now remember, you always have to use universal standard units. So if you are using different units, you have to convert it to the correct units to be able to do a calculation. Let's say if I want to get that energy, same energy, and I distribute it over many short pulses, the blue one here on the left, the blue lines will be the on, and white is off, on, off, on, off. So say I get all the areas that has been on, and I add it up into one block. That's my area. That's my energy density. That's the amount of energy I'm going to deliver. Now let's say I want to get the same area of amount of energy, but I want to deliver it instead of pulsing in one pulse only, still the same amount. Now I want to turn this down, look at your right figure, and I want to use a very low power, but I want to deliver the energy over a longer period of time. My power density is still the same. So it's very easy for you to think about your power, your energy, or your power density per pulse as the area of the power in watts times the time in seconds. And the last factor I like to stress, and this is my favorite because I think if it wasn't for this pulse design, we wouldn't be with laser technology where we are today. And this was thanks to these great scientists that developed a way of putting very, very high amount of energy inside ultra short pulses without destroying the laser medium, because that was the problem before. You couldn't put too much energy inside a pulse with our laser medium, which is what produced the laser equipment. So with the chipped pulse amplification technology development theory, that's how we started being able to now design all sorts of pulses. And you're going to see that how amazing, just by changing a pulse design, what happens to your tissue interaction, what interaction in your tissue, and of course directly is going to be represented by what you're doing in your clinical treatment. Here I put some pulses from Photona. They have a very variety of pulse designs. So here, if you can see a square shape pulse, and for instance, with that square shape pulse, it doesn't matter how long you are pulsing for. You see here on the second picture towards the right, they have various pulsing length, width, that still increasing that pulse width, they preserve with this technology the same amount of power that's being delivered. And then is the other one, adaptive shape and quantum square pulse. I'll talk about this a little bit later on. But for pulse, I wanted to remember, start thinking about the names. They're going to be listening there once you become a laser user. So pulse width is our blue arrow representing the pulse width. How wide is my pulse? Is it in microsecond, nanosecond, picoseconds? That's what's going to be your pulse width. We're going to be talking about that a lot. And then you have your pulse interval. Is the time you allow for it to cool down before you hit with the next pulse. And you can have pulse chains, which is various pulse, and then a pulse, and various pulse, and a pulse. Or you can just have it like a gated pulse, which is on, off, on, off, on, off. That was like the traditional one. And the frequency of the pulse is not the frequency of the light. The frequency of the pulse is how often that pulse repeats per second. So the pulse repetition rate, or the frequency of the pulse, or PRR, is the arrow, the orange arrow is the frequency of the pulse, how often we pulsing per second. And the TRT is the thermal relaxation time. So remember these names. TRT was developed with the theory of selective photodermolysis for aesthetic purpose by Anderson Parrish in '83. It basically states it helps to cool down the tissue so it does not cause too much damage to the surrounding tissue, because heat is diffused by law of physics. So as soon as you heat a tissue and you increase the temperature, it starts to diffuse to the neighborhood tissue in order to reach an equilibrium. So the TRT is the resting time that we give between pulses or between chain of pulses to allow this tissue to cool down. And the thermal relaxation time states that it has to be long enough so the increase in temperature you have given is reduced by 50% or more. The other thing about the pulse is going to help you is defining the for each procedure you're going to do. The pulse width, for instance, because small targets hits much faster, like a glass of water, but it goes quicker, diffuses much quicker. A larger target takes much longer to hit, like a pan of water, but it takes also longer to cool down. So the length of the pulse and the pulse design is all this is take also this into consideration. Normally, the manufacturer will give you presets, of course, these days, not when I started, and you'll be able to choose. But with time, as you get acquainted with the laser technology, and that's what I'm hoping also to pass it to you today, the importance of understanding all the influence of all these parameters inside your tissue, you're going to be modifying some of the parameters anyway. So now that leads us to the third session, is the property of the biological tissues. Let's see how this influenced the interaction. First, I want to state to you that the tissue composition that determines what happens to light. Matter determines what happens to light. It's not light who determines what happens to the tissue. That's very important because you have to understand the characteristics of the tissue that you are trying to treat to be able to predict the interaction. So, for instance, tissue components are very important. What's your tissue structure? What's the water content? How much blood circulation is within that tissue? What's the thermal conductivity for it to be diffusing with the surrounding tissue? Tissue heat capacity, tissue density, and so on. Those tissue characteristics are going to be determining your light interaction. But how do you predict the behavior of the light? I mean, how do you know? Basically, there are coefficients and indices that has been studied and fixed to be able to use mathematical models and get as close as possible to the prediction of the behavior. And that's how we study that. Now, the tissue composition also, remember I said the tissue composition, the amount of water, the amount of hemoglobin, etc., has to be in synchrony with the light frequency. Now, remember I said about frequency of pulse, now I'm talking about frequency of light. I don't like to use the same term, so normally now I'm going to start talking about wavelength. So light frequency, wavelength, that's how you're going to be hearing all the time when you're talking to laser users. Basically, the light frequency is the length of your wave. Which wavelength am I using? Am I using a short wave? Am I using a long wave? That's our wavelength. We're talking nanometers. Okay, you have meter, micrometer, nanometer. We mostly in dentistry and aesthetics, we work within the nanometer length. Okay. Now, as you go, if you look at your yellow line above, higher energy waves, the shorter the wave, the higher energy it carries, the photonic energy. But also, the more it scatters. So when it hits a tissue or a matter, a material, is going to suffer much more scattering. Remember I said that the properties of light is going to be influenced also by the tissue. So you have more scattering with those short wavelengths. So what happens is it penetrates less because it's scattering all over before it even gets down to your depth. Then if you look at our red line below, deeper tissue penetration with longer waves. So you get now, if you get it, say, from the visible light, say, let's look here, 400 nanometers under your purple, indigo light. And keep it going, you go there 500, 600 nanometers, 700 nanometers infrared. So the longer you go, the deeper the penetration. However, there is a stop there. And that stop is going to be determined by the water absorption coefficient of that particular wavelength. I'm going to understand that in a minute. The tissue components will have specific affinity to particular light, like a girlfriend and boyfriend kind of thing. So the tissue needs to like the light, otherwise it does not absorb, okay? So let's bear this in mind. The other thing is you have a high absorption of water content towards the infrared, and then around the 400 nanometers here on the blue, near the ultraviolet, you also have another curve of increase of water absorption towards the ultraviolet spectrum. But we don't work with the ultraviolet. We work sometimes with the near ultraviolet with some diodes, but ultraviolet radiation is ionizing radiation, and we work with non-ionizing radiation, and that's why it's safe, doesn't cause DNA problems. That's one of the research I did back in London in 1990. I divided now here your tissue components and your light frequencies, so you can start to position them inside one another to better understand. First, you look at the top line. You have their pigments in red, and then you have a lot of droplets of water. That means up to about 1064 nanometers, which is our diode. Now look down. Our diodes go from about 435 nanometers to 970 in dentistry. In aesthetics, facial aesthetics, we can have 1540 diodes now, which has a good absorption for water, so that starts coming out because diode is much cheaper to produce. So yes, so if you look at the pigments, they are more they absorb more wavelengths, okay, light frequencies, wavelength, on towards the ultraviolet part of the spectrum. And if you look at the left, towards the infrared, you have more absorption by water and hydroxyapatite. We're going to look at that into more detail, but what I want to look there is the hemoglobin is one of the components represented by the red light line. The yellow is the melanin represented by the yellow line, and so on. Let's look at that closer. So what are these tissue components? They basically photoreceptors that are going to decide which wavelength they are going to absorb. So again, the tissue deciding if they like that water or not and what they do with it. So that's why it's so important to understand the properties of the tissue and their interaction with light. If you want to use laser, you must know this. So what I separated, and the photoreceptors, from now on, we're going to call them chromophores, because that's what the name we give to these guys. And if you look at the little picture there, the little blue face of the guy, those are my chromophores, okay? So who are they? Normally they are absorbed in our fields, mainly by the diode and neodymium. There are pigments like hair, like tattoo, organic chemicals, chlorophyll, beta-carotene, melanin, hemoglobin, oxyhemoglobin. Those are the major ones. And if you can see there, pigments showing again the diode on the graph and the neodymium there, and all those curves of absorption. Look at the hemoglobin. It's very high for diode and neodymium, high affinity. Look at the melanin, high affinity. Now let's go to the other side of the spectrum. Remember, going towards the right, the infrared. Our chromophores there are going to be calcium, phosphate, hydroxyapatite, and water. Water started to be more have more affinity to the wavelengths start becoming have more affinity to water after 1,200 nanometers, but really peaks at 3,000. So if you look here on your top of the graph, side of the graph, it says there are erbium YAG, erbium chromium, erbium and CO2 groups. If you look at the erbium chromium, yes, it has a good absorption for water, the same as like CO2. But if you look at the erbium YAG, it's 2,940 nanometers, and that's very good for water absorption, and so it's an excellent laser for ablation because the peak absorption of water is around 3,000. We are not on the 2,940, so we're very close. So that makes erbium a very good laser of choice for ablation of any tissue, any material. But having said that, you can still do a good job with the erbium chromium and the CO2. Here is your hydroxyapatite, and you can see this CO2 has higher affinity by the hydroxyapatite. And the erbium by water. So why does this matter? If you want to do specific procedures, you want a laser that does the best performance for you for that procedure. So what I did, I divided to make it easier for you into two groups, a soft tissue laser group and a hard tissue laser. Soft tissue laser, those that are highly absorbed by tissue pigment. Hard tissue lasers, those that are highly absorbed by water. So soft tissue lasers are classified diode and neodymium. Hard tissue laser, I put erbium, the whole group of erbium and CO2. Then if you notice at the bottom of the soft tissue laser box, I also incorporated the erbium CO2 because when ablating, okay, when you're cutting or evaporating or pulverizing tissue, you will be targeting water. And that's why we called erbium and CO2 a all tissue laser. Let's get the first group, which is the lasers that are well absorbed by pigments, neodymium and diodes, and they have good deep penetration, which you need for photobiomodulation, absolutely, and for many facial procedures like non-ablative skin rejuvenation. You need that laser to penetrate to your dermis and sometimes to the subcutaneous tissue. So are they good for? They're very good for periodontal treatment. You have inflamed tissue, you have high concentration of hemoglobin, so lots of chromophores, coagulation, lots of chromophores, hemostasis, photobiomodulation, of course, antisepsis and disinfection. I was going to put a chapter on this here, but there's so much to talk about and not enough time, but it's been a wonderful research that I'm preparing a webinar that shows the neodymium and the diode being fantastic for disinfection and able to produce disinfection at a certain amount of energy that before it produces any heat or damage to your tissue, but that's another conversation. And it's been showing that the diode 810, for instance, is amazingly absorbed by most periodontal disease bacteria because of their pigments. So soft tissue surgery, yes, you can cut with soft tissue, not hard, with those lasers. They'll cut it through a different mechanism, which I'll explain later. There is a photoablative, it's not photoacoustic, like you can do with the erbium CO2. Fibrin formation, and all of those. What I wanted to remember is if using neodymium and diodes, you can use either in contact or non-contact, but when you are ablating, you're cutting, you want to activate the tip if it doesn't come already activated. And the reason is because, remember, it's very highly absorbed by pigment. So what you, in essence, doing, you're putting pigment on that tip and you're activating the heat. And the heat is going to absorb by that pigment on the tip and turning this into a hot piece of quartz. So that's why it's kind of a different mechanism for cutting. And you would use for cutting, you normally use it in contact. Hard tissue procedures, as I said, you would need erbium or CO2 because they are highly absorbed by water and also because they have superficial penetration. We don't want that. Those lasers that you are trying to cut the layers of tissue to be penetrating, otherwise you cause tissue necrosis. And the reason now you understand why they are safe, because you see, I'm giving a large amount of energy there, but they're not causing any secondary tissue damages because they are not absorbed deep down. So they are excellent for cutting soft tissue, tooth, bone, anything really, dental materials. So cavity preparation is great with those lasers because you remove this mirror layer, you leave a very beautiful prepared cavity that will increase your bone strength. For bone surgery and soft tissue surgery, they are excellent because they will also not only produce the disinfection, but they also will increase the rate of healing, and you're going to see that on the following slides. And periodontal procedures is also very good for you when you're doing scaling of the root surface. You're targeting the calculus that's there. So you're targeting hard tissue without having to provoke further thermal diffusion. And it does have, also can do the other effects of the previous soft tissue laser that we talked about, but this time in a different mechanism. We're going to see that in the mechanism of action, that it can do coagulation, hemostasis, disinfection, fibrin formation, but it's through another mechanism. It's a thermal mechanism. It's not via the absorption of the chromophores. Now, the all tissue procedures, basically for dentistry in the US, the lasers with most FDA clearances are the erbium group, and for aesthetics is both CO2 and erbium. Actually, CO2 started in the aesthetic field, and the erbium now we are now close here. Now, what I want to reinforce to you with this laser is that bone and soft tissue surgery will give you an atraumatic and a very fast healing. And now you're going to understand why with our comparative studies. It's been shown that the wound will not heal in the presence of any beta-hemolytic streptococcus. It's been shown that the wound will not heal if you have over an amount of any bacterial species per gram of tissue. And it has been shown in the studies that the wound will take much longer to heal in the presence of foreign bodies. Now let's think of our microorganisms here. In the presence of motion and in the presence of pressure. Now let's compare our laser with a handpiece. Say you're doing a bone surgery or you're doing a soft tissue surgery. The laser will have no pressure, promote no pressure, no vibration, no thermal side effects, and will give you disinfection. So that's why the logic seems to fit with the practice, that we find much faster healing and minimal or no post-op pain with procedures such as those done with lasers. Now I want to compare the laser with the electrosurgery. Electrosurgery has no tissue selectivity. It's basically just a piece of hot iron. So it's just the heat purely, no chromophores, and the zone of necrosis of the electrosurgery is much, much deeper. With the erbium and CO2 can go to 40 micrometers, diode maximum and neodymium 500. And if you can see, electrosurgery starts at 500 micrometers. You can go as deep as 1,500. Now here I compared, I chose some techniques, and I compared here the erbium laser, which is the one I said would be good for ablation, and here is a preparation on bone, and you can see very nice and clean cut, no thermal cracking, no signs of thermal injury, and your surgical burr on bone with thermal cracking. Now I got a laser that I suggested to be a soft tissue laser, but this was used in a hard tissue enamel. So as you would expect, you have surrounding thermal cracking on your tissue because it's not the correct laser to use for hard tissue. Now here the rotatory burr, of course that causes heat, and as expected, if you put under the microscope, you see that it causes also thermal cracking. So what's the mechanism of action? What's happening inside there when you choose your laser? Here's the three groups, the major three groups that a light or a laser light is going to be interacting with your tissues. You have the photochemistry group, which is purely non-thermal, no thermal. And that's the photochemical mechanism and the photoelectrical mechanism. They are both in the same group because they're both, none of them are thermal. And then you have the photothermal mechanism, which is activated and affected by heat. And your third one, which is the photomechanic or photoacoustic or photodisruptive. People like to name in different ways, but basically that's a mechanic waves. You have your light transforming this energy in thermal, and then it builds up the energy, and eventually you transform into kinetic energy, which is mechanic. Photochemical, I want to stress again, is absolutely no thermal, and that's the beauty of the photobiomodulation therapy. As Dr. Cynthia mentioned, I'm a lover of photobiomodulation. I've done for over 30 years. Is the fundamental behind APDT, PDT, photocatalytic disinfection, and photobleaching, and also the photoelectrical, which I just put there so you remember is not a thermal organic reaction. Photochemical is basically, the examples will be the photosynthesis and the synthesis of vitamin D. I want to stress that it's absolutely not activated by heat at all, because if you get a plant and you put inside a pot in the dark, but a very hot compartment, your plant is going to die because it's not going to do photosynthesis. There are no photons there to activate. Same thing, you get a piece of hot iron and you put on your skin, you're not going to produce vitamin D because the chromophore for vitamin D is looking at you and say, where is my light? Where is my photon? So I want to stress this, that photobiomodulation works. I've seen this working for many years, and don't try to look for heat behind photobiomodulation because you're not going to find it. Actually, there's a physics theory that explains that when a thermal chemical reaction is, if it's thermal and you add heat, you can improve the thermal reaction or accelerate. But if it's exothermal or no heat involved and you add the heat, you can inhibit or reverse. So that may explain our window therapy dosage, that after a certain amount, that if you keep giving longer doses, you inhibit, because my theory is that you probably now is starting to build up the heat. And if you put the heat in an exothermal chemical reaction, you inhibit or you reverse, if it's still reversible. We're going to talk about this on the photothermal. So basically what you need a photon, so your molecule can absorb the photon, that molecule is going to be reactive, and it's going to change its property, either physically or chemically. If it changes physically, it goes towards your left-hand corner here. It's going to activate the organic chemistry reaction that's photophysical. So you produce fluorescence, phosphorescence. If it suffered a chemical change, change on the chemical properties, its chemical properties is going to go towards the right, which is our photochemical process. So you have oxidation, reduction, all those that you get with photobiomodulation and photosensitization, like the PDT, etc. And then is the purple mechanism there, which is photoelectric, is not important for us. But let's say, why does, how can you explain this non-thermal? Light-induced chemical reaction has huge advantage for the biological system. It's been developed within the biological system for years and years, because it can activate very high energy chemical reaction that otherwise would not be able to be activated by heat. It can overcome very large activation barriers, and also can be extremely fast, much faster than many thermal reactions. So it's our tissue developing mechanism of survival. Now let's talk about the photochemical, our photothermal, our second mechanism. You can do photothermal with any laser, providing it has enough photonic energy to produce temperature. That temperature is from photonic energy is going to be converted into heat, thermal energy, and that thermal energy, if you leave it enough time, is going to produce pressure changes. That pressure change is going to promote thermal expansion, and that thermal expansion is going to propagate it through your tissue via thermal waves. Now, this is very exciting because that's a photothermal mechanism, but how does that affect us clinically? What does that do? What's the effect of this photothermal mechanism? Just want to remind you about denaturing and coagulation. Denaturing of protein and coagulation of protein, they are both chemical reactions that involve protein. So let's say a few points here to be able to explain what comes next. Denaturing produces permanent alteration of your protein, breaks your chemical bonds, and etc. The coagulation produces cross-linked fibrin formation, and then you have your aggregation of platelets in it. So that's your coagulation. It's been showing that protein can denature within the same protein type, can have different fragments that denature at different rates or by different amount of energy. So it can be triggered by different amount of energy or by different amount of heat. Fibrin and fibrinogens are protein, right? And it's being shown that those fibrinogen and fibrins have three distinct stages for denaturing. And you're going to see why I'm saying this. Your coagulation happens up to a temperature of about 41 degrees. You already have that's your temperature to form coagulation. You start with a slightly thermal for the activation, which by 40 degrees, say if you're doing it outside the body, by 40 degrees it's still thermal, you can still increase the rate of coagulation. After 40 becomes exothermic, exothermic. So remember I said, in an exothermic, you leave it to alone, you don't want to give heat to that. Up to then at 56 degrees. So there you have your coagulation nicely formed. And if you give heat to at 60 degrees to a coagulum, okay, you're going to start like melting it away. The viscosity it increases, become more running. That's because you're dissociating protein cross-link. If you do that between 56 and 60 degrees. So that's the first, 60, 55, 56, sorry, is the first denaturing. Remember I said there were 3 fragments temperature. At 60, you can again denature the other part of the molecule. Now you have 2 denatured parts. So up to then, they are like small subunits. So the viscosity is being reduced. But at 100 degrees, you have your third and last part of the protein that can be denatured. And if you give it between 60 and 100, you actually, instead of reducing the viscosity, becoming runnier, it actually gets more dense. So you increase viscosity. And that's all due, not because you're promoting coagulation. You are denaturing the fibrin. That's what you're doing. You're denaturing fibrin, but you're doing in steps. So between 56 and 60 is going to decrease your viscosity. If you give between 60 and 100, you're going to increase the viscosity. So let's go now to our thing. What happens to our tissues when we're giving heat up to 41 Celsius? And I'll be going to be talking Celsius because that's what we use in most part of the world. You cause absolutely no irreversible tissue damage. You can leave that forever in your skin, or you're not going to cause any damage. But when you get to 41 to 50, you're beginning the dissociation of the crosslinks of the protein, and you start at that temperature, the irreversible transition into denatured state. That's when you get enzymatic changes and you start seeing signs of edema. So between 41 and 50, you start seeing edema. This is very important because when we're working on the skin, and remember I said sometimes you want to get deep heat under the skin, in the dermis for aesthetics, you cannot let your skin to suffer the nature protein of the skin. You're trying to just increase collagen formation below it. So you want to have 60 degrees below inside the dermis, but you want the epidermis to stay at 41, 42, and that's very tricky. But we have ways. So at 60 is denaturing your protein. That's the temperature you cook your egg. If you say put your eggs there 41 degrees in the morning and expect to have your dinner ready in the night, it's still going to be raw. So you need the right temperature to denature your protein. Albumin, of course, is pure protein. And the bacterial deactivation also occurs at that temperature. So it's about 60 degrees, you're shining your laser. That's also when you're starting to see disinfection. At 90 to 100, you start getting the desiccation of the tissue and shrinkage. And 100 being our boiling point of water. And remember, we're talking ablation now. The water in the tissue is going to start increasing in temperature, raising pressure, and all those things I said about the pressure waves building up, and you get the photothermal ablation. And the exposure of this tissue is via hydrodynamic mechanism, which is like micro explosion, because the water state changing from liquid to gas. This is the type of ablation you do with neodymium diode. And the next level you cannot reach with those guys because technology. So pulse and pulse building limitation, power and pulse building limitation with those guys. But, pardon, you can go to the next level with the erbium CO2 because, and we use that for skin resurfacing and dental ablation, because for that, you don't need just 100 degrees centigrade. You also need to increase, to build up an amount of energy into your target to be able to convert the thermal energy into kinetic or mechanical or acoustic energy. And that, I'm going to show you that how does that happen. But normally you have to use high power and short pulse. And remember, I said the laser technology, you need special parameters for that. And if you go above 200, you will provoke burn and carbonization. And basically here is our gradual change depending on the energy you are delivering. So if you can see up there on 100, you have photothermal ablation, which is the cutting, and you have photoacoustic ablation, which we call cold ablation. That brings us to the third one, which is the photoacoustic, which you just show the cold ablation. And how does that work? Basically, you have light waves and enough photonic energy to cause the thermal waves, which then builds up energy to change into sound waves. Yes, sound waves, mechanical waves. You need special conditions for that. You need to have very high power placed into ultra short pulses. And these pulses have to oscillate in intensity. So the light has to be modulated light. And the application you can use for anything. Cold ablation you can use for all types of materials. And in our area would be talk about hard tissue, soft tissue, dental material, pigment, whatever. And the advantage is is that it does not cause thermal damage, no micro leak cracks, and absorption is less wavelength dependent. And this is how it works. You have your pulse light and your water interaction with it, and that provokes, causes the heat and thermal expansion due to the heat, thermal waves, and the energy, thermal energy is converted into kinetic, which is mechanical. Then you have the disruption of your tissue matrix and changing the state of matter. Now liquid turning to gas, and you have micro explosion and pulverization with no residual heat. That brings us to our last session, which is the ablation versus delivery mode, and how can that influence our effect. Say if you want to do coagulation, you normally use low energy with longer pulse. Ablation, remember I said, high energy, short pulse. But also if you, depending on how you pulse and how much energy you're playing with it, you can, by changing the delivery mode, determine if you're going to have a photothermal or photoacoustic effect. And as regarding ablation or cutting, you can expose the material in two ways, by either evaporation, which is the photothermal, or pulverization with the cold ablation with ultra short pulses. Here I made an example just to show you the illustration how changing power and pulse can amazingly influence completely with the type of ablation you are getting. So here this is a graphic from Photona, which I modified. And you can see that on the left, your pulse energy in millijoules, there is an amount of energy that below that you cannot produce any ablation, of course, is expected. So what I did, I fixed here 600 microseconds. So I'm using the same pulse width. Now I'm going to be increasing my energy in millijoules, okay? The energy inside the pulse. So at 200, if you can see there, I have hot ablation, 400 warm ablation, 700 cold ablation. So I changed my mode of ablation just by messing about with the power. Now I'm going to do the opposite. I'm going to fix the pulse energy in millijoules. I fixed at 400 millijoules, so the energy is fixed, and I'm going to play with the pulse duration, the pulse width. So at 400, you have my cold ablation. And at 600, look at that, I can go to warm ablation. And now I go to 1,000 and I'm into hot ablation. And I did not do anything with power. So that just shows you the importance of understanding how to play with those parameters. So power, for instance, you will reduce when you are treating deep dentin because you want to reduce the speed and you want to cut a bit slower. And in soft tissue surgery, it is a softer tissue, so you don't need so much energy. And in aesthetics, for instance, if you are treating darker skin types with more melanin, you also reduce the power. But don't be fooled thinking that just increasing power or pulse repetition rate or frequency, you're going to be just, oh, I'll increase power and I'll increase my ablation rate or speed. You can cause thermal injury if you don't know what you're doing. And here, finishing off, we have the pulse width that can go from longer to shorter, and you have second, millisecond, microsecond, all the way to picos, femtosecond. And what I just want to show in the next illustration is depending what pulse width can do also with particle fragmentation. And if you look here on the red part of the arrow, we have nanoseconds. And if you look across, you have a photothermal ablation. And when you go up there to picoseconds, you have a completely different type of shockwave propagation and fragmentation breakage. And here, showing the pulse width again, you have the nanosecond laser and a ultra short pulse laser. You can see that with the nanosecond, you can have, let's read from right to left, damaged surface, heated affected zone. You get heat transfer surrounding to surrounding tissue, shock waves, you can get cracking, and you get surface debris on your ejected material. Now, if you look at the right figure, you see that with the ultra short pulse, you have no damaged surface. And the next box, you can see no heat transfer to surrounding material, no shock waves or motion or vibration, no melting zone, no cracking, no debris, and you're going to notice there a narrow sand plasma plume. That's the way these ultra short cold ablative lasers release the ejected material via a plasma. And this plasma, also known as plume and or clouds, are basically the interaction between the gaseous particles that you ablated with the next laser beam, photons. And that can reduce, as it builds up, it can reduce the cold quality of your ablation. Also, it will reduce the efficiency, as you can imagine. So this plasma plume is interesting to try and reduce as much as possible. And investigation has shown that it takes about 50 microseconds to form. So photona laser, again, is one that came up with quantum square pulse technology that they keep the pulse up to 50 microseconds. So just enough time before the plasma plume starts to be produced. And then they leave also longer pulse interval, so any plasma produced will disperse. And that's their latest pulse technology. So my conclusion to you is a mistake that just increasing energy alone may result in quicker cutting because it can provoke tissue necrosis and lateral thermal damage. So setting and understanding your setting is very important. In aesthetics, we use a laser combination to get best performance depending on what you want to do. Say, basically, if you want to do some very specific procedures like pigmented lesions, tattoo removal. But overall, modern laser technology is possible with one device for most applications. You can do minimally invasive dental and facial procedures with it, and it's fast, less invasive, and better has a better outcome than our traditional techniques. And if you already have a laser, my takeaway for you is to start offering other procedures. You can do gingival depigmentation with diode lasers. You can do teeth whitening. You can do, if you have all tissue laser, snoring treatment, facial rejuvenation, and it's not very difficult. That um, all tissue laser I talked about, 150,000 that has many hundred pieces for the snoring, facial rejuvenation. So my takeaway for you is that in order to increase to meet the increased demand of the aesthetic expectation of our patients, we have to start looking beyond the teeth. You have an amazing tool out there. Don't think that, oh, I have a laser, a dental laser, I'm a dentist, I'm going to do just things inside the mouth. You start including the whole oral maxillofacial areas. And then you can say, okay, I'm giving a great looking smile, and laser are great tools because you can do that with minimally invasive orofacial harmonization techniques and keep your patients very happy. And if you don't have a laser, think about bringing a ray of light into your life. So sorry, I might have extended a little bit beyond. I'll be very happy. If you don't have time for a question, I'll be very happy to answer any questions via email. I normally answer everybody. So I would like to say thank you for listening. And my apologies for going a bit over the time. I just get too excited when I'm talking about lasers. So please take a screenshot of my contact. Thank you. Um,
Thank you, Dr. Sonia. It was mind blowing. It was mind blowing. I have a diode laser in my practice, and um, uh, the details you talked about was amazing. It is one of the best lectures I have ever heard. Let me tell you, it was the best lectures, and as I said, it was mind blowing. Talking about the intricate details about lasers. Lot many people, they buy and they go as per the company's protocol and how the company they present in front of the dental surgeons, because they do not know the physics behind that. They have no idea, and most of the lasers are sold on to this idea that, oh, the wattage, and this is 10 watts, this is 12, or this is more. But that, I believe that now, by listening to you and one of my friend whom I call the laser man of India, Dr. Nitish Kamboj in India, he has all kind of lasers with him, and he has updated me a lot onto lasers, and that is amazing because the frequency is more important. Then what kind of
mhm,
pulsation is there? The short pulses, the long pulses, and the wattage is not so important, because most of the time you are ending up charring the
correct.
tissue, as you, yeah, as you said. So I think the viewers had a great time. knowing about the ND-YAG and the CO2 and the air-YAG lasers, ER-YAG and the diode lasers, because diode are the
Uh-huh.
most common one. They are the most common one into the dental practice. But I believe that once we go into, because I read a book, the biology of belief by Professor Lipton. He's a cell biologist from US,
Mm.
and he had talked about this frequency analysis, that everything, whether it is living or non-living, has certain frequency, the molecular frequency. And when a healing frequency of a cell matches with the photo frequency of a laser, it doesn't damage that cell, it heals. This is what I believe. That is the holistic approach, I believe.
Yes, you're absolutely right.
So, yeah, so he talked about something like I was going through the one of the Wikipedia, and it said that there are certain stingray or some fish which or some sea creature, it gives light at such a high pulsating rate that it converts into a sound energy and creates a burst. It creates a burst, and it gives it's like a weapon for that particular organism to give a shock to the predators. So this is
Yes.
what is happening. You have explained it very nicely here, that when a short pulsing laser with a short pulsation with a very high frequency, when it goes in there, it cuts, and there are no cracks, nothing. And even the coagulation procedure which you explained, that I believe it helps in the growth factors to coagulate that, if you do it with the laser. And I want
Mhm.
to ask you one question, that when you are doing a facial rejuvenation, uh, what is the exact frequency which you keep on your uh, uh, hard and soft tissue laser, so that it enhances the collagen formation?
When if you talk about frequency, it's very difficult to talk about pulse
Okay,
frequency because it's like comparing apple to pear because the different machines depend on the device you're using. So I prefer
okay,
to talk about the energy and the buildup of energy and what I'm trying to do down there. So basically, let's say example now. We're going a lot to away from full ablative, which is just ablating the skin with like the CO2 in one go, because of course you have all those post op um, hurt and people be for 2 weeks downtime, longer downtime. So we're doing a lot of non-ablative, which is that's the reason I wanted to explain about the coagulation and the denaturing. What we're
yeah, yeah,
targeting when we're doing skin rejuvenation nowadays is to increase the temperature of the dermis approximately to 60 degrees.
hmm,
As you can see, a little bit before you already start getting denaturing, but we want to denature the proteins. That's what we want
okay,
to do. And now what we're doing with micro holes. So think about like a lot of, as if it was a lot of needles, but with a laser. So you
yeah,
leave it surrounding, you leave untouched tissue around those little points that you damaged, you provoked deliberately uh, uh, irreversible damage, which are
hmm,
irreversible denaturing of the protein on those um, points. And we noticed that by doing that, rather than doing like a full um, ablation, which the downtime is so much longer, you can get as good results. Just means that you do a few extra sessions, but it is amazing the result, and a person has absolutely no downtime at all. You go to do your skin rejuvenation and you walk out and go to work. And
Yeah.
what you're doing, you're operating deep down into dermis. And what we have to be careful, the reason I put there that below 41 you don't cause the tissue damage is because you see that with laser hand pieces that do the facial, we do what we call bulk heating. Say if we're doing um, heating of the dermis to generate some damage there, uh, we have to be very careful that we don't go over 41 at the surface of the skin. So we have to
Okay.
play. Imagine now you're treating a person with a dark skin color. You have to know how to play with your power and your frequency. Otherwise, you're going to burn that skin even before you think about reaching 60 degrees below your dermis. So
Yeah.
the equipment have thermometers now that they use either as a scanner or some machines have some device use handheld thermometer that you have to keep monitoring all the time this
Yeah.
temperature of the surface of the skin of that person. But I don't know if I answered your question.
Yeah, yeah, it was wonderful having you here. And let me tell you, the idea came to my mind that you should come down to India
I would
for
love to. I
and
want
and
to.
and definitely I'm going to take the number of yours from Kianor, Dr. Kianor or Anshul. I will ask your number, and I'm going to invite you to India for the laser. Uh, uh, um, uh, Workshop, which is very much required here in India. And thank you so much for being with us and giving such a detailed and wonderful insight into the laser world, the photodynamic therapy, and the photobiomodulation.
Nice
And
to see you.
it was amazing having you here with us on Global Summit. And my best wishes to you. I think you must be going back to your work also these days now, with the post COVID lockdown being opened all around the world. And best wishes to your family and to the people around you. Take care, stay safe, and a big namaste from India.
Namaste. It was
Yeah,
my pleasure having you and being here with you all. Thank you very
thank you.
much.
Thank you so much. Thank you
Thank
so
you.
much. Yeah, bye bye.
Bye bye.